All right, guys, let's get back to it. We're going to start on trauma. As far as the major considerations for trauma, paramedics should be able to gain a good deal of information about the patient that will assist them in the management based on factors identified prior to meeting the patient. All right, so let's get down to the brass tacks here. What actually matters for this? Trauma is the leading cause of death in children. In fact, it's the leading cause of death anyone under the age of 34. Well, anyone from the age of 5 to 34. Motor vehicle collisions, I should say, are the leading cause of death for anyone aged 5 to 34. Trauma is the leading cause of death in children, usually from motor vehicle accidents, but also from falls. Excuse me. In fact, motor vehicle accidents are so damaging that 1 out of every 70 Americans will die from a motor vehicle accident. Over half those crashes will involve alcohol. Are these numbers going down? Absolutely they are. When I've run on traffic accidents on the highway with amazing mechanisms of injury where people have survived because of good airbags, good roll cages, good car design, crumple zones and bumpers, changes in building and car materials. All of these things have contributed to fewer and fewer deaths as we've gone on forward. However, there's still a lot of people out there driving their cars from the 90s. So this still can definitely happen. Now, all of that is very sobering, but it only covers the immediate impact of trauma, which is what we see. The long-term effects of trauma are that it can be very debilitating. Like, most people are going to experience these things forever, perhaps for the rest of their lives. Chronic pain is one of the big things that's caused the opioid epidemic here in the United States. You get in an accident, you hurt your arm, you hurt your shoulder, you hurt your back, you hurt your knees, your hip, whatever. You start taking pain pills because there's nothing we can really do about that. The human body is really good at healing itself for some things. Other things, it just cannot heal. Trauma can reduce the years of your effective life. It can cause damages to your ability to work, your ability to enjoy life. Potentially billions of dollars are caused by trauma every single year that we can't really even account for because it's a very complex subject. We know that the only definitive treatment we have for trauma patients is getting them to the hospital. So everything we are ideally facing with trauma is about minimizing our time on scene and maximizing the transport to a trauma facility. So how do we best manage that? Well, one thing to keep in mind is traumas are easy, all things considered. And what I mean by easy isn't that they don't take a lot of skill to perform well, because they do. What I mean is, in a United States EMS capacity, we're realistically not going to have to be in charge of the emergency surgeries. We just need to facilitate transport to a hospital. So our role in trauma is going to be limited. Now, if you work in an ER, if you work overseas, if you're working in some sort of trauma hospital, yeah, absolutely, you're going to be a lot more involved. That being said, what's important for us to understand about trauma is how to maintain it and how to keep the patient as stable as possible. So all of our efforts need to be directed towards that one goal. Excuse me. I got to hawk this loogie sometime or later. My goodness. All right. Mechanism of injury is what we will use to talk about this idea where we're trying to get a handle on what exactly might be wrong with the patient based on the type of damage they're experiencing. 1 second, guys. All right, sorry about that, guys. Let me see what you're saying there. Do you use March protocols for trauma in the civilian world? No, I'm not familiar with March protocols. Can you explain what those are? We use a lot of different protocols when we're talking about it. The big ones that we're kind of going back and forth on are Glasgow Coma scale is very important. And then there's this whole concept of the platinum 10 and then the golden hour, which is when we're trying to reverse the causes of shock within 1 hour.
Right. Can you hear me?
Yeah, I can hear you. Go ahead.
All right, so March protocols are what we do is, because massive bleeding is the thing that's going to kill somebody the first, first and foremost if you're bleeding out. So March goes with massive bleeding. Airway would be the second thing that's going to kill somebody. Respiratory would be the third thing in that line of hierarchy. Circulation, is it there? Is it not there? And then you got your H's and T's, head to toe, hypothermia, and then your other stuff. That's what March protocol is. And what it keeps you in line, it's basically a no set assessment protocol for just about acute medicine, which I do very rarely of, but trauma assessment protocols. It just keeps you in line, and it keeps you in track with how the body actually, dies in this assessment protocol. So if you stay within those lines, massive bleeding first, airway, respiratory, circulation, head. So I'm just wondering if that's what you guys do. But
no, that's not. That's something that's new. All right, can you go over that one time? Massive bleeding, airway. It was a respiratory compromise.
yeah, so what we do is when we're assessing a person, we come up as massive bleeding, and this is where we're doing primary assessments and whatever, secondary, tertiary. It's just a roadmap that we always use. Massive bleeding, that's going to be the thing that's going to kill somebody first and foremost, no matter what, because you can die from catastrophic wounds to arteries in under 2 minutes. You not saying that all the blood has left your body for you to die, but enough blood that you won't recover from, and that can happen within under 2 minutes. So that's why massive bleeding is up front. Airway is the next succession in the line of death, and if people want to follow the death triangle, this kind of like correlates with that. So airway, which is going to cause acidosis, correct? If you're not breathing. So airway plus, not getting glucose, oxygen, blood to the brain. Respiratory, well, do they have a respiratory compromise? So do they get shot through the chest, etc.? Is there equal rise and fall of the chest? So is there actually a respiratory process? Is there perfusion going on? And that's all that really means. And then circulation is, well, are we getting that blood back to the head? Because any traumatic patient should be conscious. If they're not conscious, yeah, it's a bad deal. It's really bad. And then your head injuries, which you can only really do supportive care. Hypothermia, which is the next thing that is really going to kill somebody. And that, I don't know about civilians, but in my world, this is a thing that we always set people up for success. Hypothermia, because we stripped them down, got them into a helicopter, got them up at elevation, and continued the process of them getting hypothermic. So, and then we would just start over with the March protocol. But as you guys are familiar with, you go into different protocols of getting deeper into medical treatment.
Interesting. So to answer your question, no, that's not really a thing we use in EMS. People use all sorts of different acronyms depending on where they're from and what's convenient for them. I've never heard of the March one. Which branch of the military are you in again?
I was in the Air Force. I'm a retired pararescueman, so we're kind of like the guys who did 911 for the SEALs when they got their ass in trouble.
Yeah. So I don't know if that's specific to all military branches or just specific to your military branch. I like it. I've never heard of it before, but all those things you're saying are all making sense. It's similar to the way I would say that we approach traumas in EMS here in the United States. I will say that the main difference is, though, that we're not dealing with traumas nearly to the extent that you guys would be over there, right? In fact, you're primarily a trauma medics. In fact, all the Army medics and paratroopers and the PJs that I've gone through school with, some of the best trauma medics out there. Here in the United States, though, it's going to be fewer trauma calls, more medical side.
Yeah, we're great at trauma. That's why I was reaching out to you for all that, saying like, I'm horrible at all the stuff that you guys are so good at.
Well, we're pretty bad at it too, because realistically, it's a lot to cover, and there's not a whole lot we can do for a lot of it. As far as what you're talking about, though, with these trauma principles, I will say that all the advancements in the EMS side that we get from trauma come from military practice, because the military has a huge source of people that it can essentially experiment on without any sort of compromise or any liability. And that's very helpful to us as EMS practitioners, because we see things that might work, and then we see things that do work, and we also learn about things that do not work and why we stop doing them. For example, something we're going to go over a little bit later is the pneumatic anti-shock garment, which I'm sure you've experienced a time or two again in your career. Everyone I've talked to that's used them in the military settings has said that they work great. However, all research we can do about those pneumatic anti-shock garments does not really show any sort of positive correlation with survivability. So it's interesting that while we might have things that anecdotally seem to be really working well, like the research and all the science really isn't supporting them as things. So we tend to move on from them. I'm sure that's one thing that you've used that you can, for an example, but there's probably a lot more of them. Don't work well with aerial flight. I can see that, probably with changes in air pressure, I can imagine.
Yeah,
That's
it's just like with intubating patients, like when we, we intubated somebody at ground level, what we found when we got up to altitude, we would lose we would lose like end-tidal CO2, so their hypoxic drive. And that's what we realized, like, we got to stop inflating these guys with air. And what we need to do is put saline in there, because saline isn't going to decompress.
That's not something I would have considered. I've had flight medics before take this course, and I've never heard them mention anything. Now, I don't know if it's different depending on the type of aircraft. I know some helicopters don't go as high as like a fixed wing aircraft, and I know that most cabins are pressurized, but in military planes, I know that may or may not be the case. So
yeah, this is a phenomenon. Yeah, this was a phenomenon that we ran into in Bagram, where we're running, which is in Afghanistan. We're running at 6,000 feet above sea level already. So a lot of the places that we were fighting in and we were working with, and this can happen. It doesn't matter where you work. If you're working in high altitude places as a flight medic or anybody, this is something that you want to think, especially if you're losing end-tidal CO2, that'd be your first indicator, is that there's a cuff leakage. So we mitigated that with saline, and we never ever have to worry about an air process again.
That's really interesting. That's not something that I've had any experience with, Phil. So I'm glad you brought that up. I would have to do some research on that and see. That's not something I've ever experienced, because I like to keep my feet planted firmly on the ground. But that's really interesting. Thank you for sharing all that. Yeah, no, that's very cool. Like I was saying, most of our trauma advancements come from the military, which makes sense because military, they have a huge surplus of people that are otherwise healthy that are now undergoing some acute traumatic situations, burns, explosions, concussive events, gunshot wounds, stabbings. Obviously, we're going to see a lot of repeated stuff. And that way that anyone gets better in this field is by dealing with repeated situations over and over again. The very first time you respond to an emergency, you're not going to do very good. Or let me rephrase that. You're not going to do very well. You're going to do a very poor job at it. You're going to have a lot of problems. You're going to stumble your way through a few things, and you're going to make mistakes. The next time you do that, you're going to cover those mistakes you did last time, and you're going to discover something new that you messed up. The third time you do it, you should be pretty solid. And that's kind of the way I've experienced a lot of this in the EMS field. Now, as I was telling Phil, we get fewer trauma calls than obviously military paramedics do. And that should make sense, right? They're dealing with a lot fewer medical calls. So it's helpful to have people that can specialize in both fields when we're dealing with these sorts of emergencies. Not always possible, but this is a big reason why ex-military find a home in the fire service when they get out, or in EMS afterwards, because it's nice to have kind of that regimented response with dynamic workforces and your own autonomy to make your own decisions when you need to. Now, what do we need to consider as the main things we're looking for with trauma? The mechanism of injury, right? A gunshot wound is very different than a low impact car accident. It's very different than a high speed car accident. It's very different than a pedestrian struck. Is different than a fall from standing. Is different than a fall off a ladder. All of these things are calls that we might experience. And every single one of them is going to present very differently. So what's the methodology? How do we want to approach these patients? Well, again, the way I approach a trauma patient and the way someone like Phil, who's probably worked on 10 times, oh, let's really rephrase that. He's probably worked on 1,000 times as many trauma patients as I have, I would hope are not terribly different. Here's my main considerations when I'm seeing a trauma patient in front of me. And for the sake of argument, let's go ahead and say that this is a severe trauma patient. Getting away from gunshots for a second, because that's its own specialized thing. Let's pretend that we've got a pedestrian struck by a vehicle at a high rate of speed. I think we can all agree that that would be what we would all consider to be a very extreme mechanism of injury. Lots of comorbidities facing this patient. Very small chance that they're going to be conscious. Possibly we might even be in blunt traumatic arrest. How do we approach a situation like that? My mindset is always on maintaining my own safety first and foremost. And I know that it sounds like a broken record to say, you know, BSI, scene safety, but you need to get in the habit of that. When you're in a war zone, that's not always possible. And there's a different kind of brotherhood dynamic. When you're dealing with someone that you work with or know personally, it's a different mindset than when you're responding for a complete stranger. Heavy leather gloves, yeah, oh, that's a big part of it. So here's my impression of trauma. We're rolling up on scene, someone's laying on the ground, they're all mangled up. What's the first thing we want to deal with? My mind tells me that we need to get this person to the hospital ASAP. That's my ultimate priority. Everything else is going to be extra credit. Getting them safely to the hospital is first and foremost. So outside of that, what are our major priorities? Well, the first one should always be exposing that patient to see what you're dealing with. So the trauma shears are one of the first things I need to have on scene. Tourniquets are great. Your trauma bag is a necessary thing, obviously. A backboard is going to be absolutely necessary to extract this patient safely. But what we really need to do is we need to assess and determine what sort of life threats are facing them. Now, I don't always think of bleeding as being the top priority. It makes sense, though, in these trauma aspects that we would. Now, for someone hit by a car, we're probably going to be dealing with more internal bleeding than external bleeding. Someone who's been shot by a gun or stabbed, now we might need to worry about hemorrhage control a little more rapidly. But the first thing is exposure of the patient, at least cutting off their shirt, probably cutting off as much of their clothing as we can, because we need to be able to assess where the injuries are. The primary injuries we're looking for is anything involving the chest, the thorax. This would include some sort of sucking chest wound, maybe pneumothoraxes, or any sort of flail chest, injuries like that, things that can happen from blunt traumatic mechanisms of injury. We need to then deal with those problems first and foremost. And we're going to go over how you deal with flail chest, how you deal with sucking chest wounds, how you deal with pneumothoraxes, hemothoraxes, things like that. Not all of them we're going to be able to deal with. For example, most paramedics are not going to be performing pericardiocentesis, which is when the pericardium starts leaking blood into it, and we need to put it like a 14 gauge needle in there to drain some of that fluid out. You might not have that ability. If you're a flight medic, you might not. Military medics definitely doing stuff like that. Military medics are also doing chest needle T decompression. We're doing that here in San Diego too. Flail chest is the other one that we were talking about. That one's changed a little bit. A few years ago, we were talking about stabilizing it with like bulky dressings. Now we're talking about putting your hands first and foremost there, putting your hands to hold their rib cage as much as one unit as you can in order to facilitate their breathing until you can get those bulky dressings on. That's how we're going to externally stabilize their chest. Besides that, we're also going to want to internally stabilize their chest, probably through the use of some sort of positive pressure airway, like a BVM, something like that. So it's external stabilization and internal stabilization as well. After we deal with those, the next consideration is going to be packaging and transport. And then en route is when I'm going to take care of everything else. I don't want to get an IV on scene. If I really need access, I can maybe go for an IO, or I can start something in the back of the ambulance. The most important thing is initiating transport, ASAP. What's called the Platinum 10, We want to try to be on scene less than 10 minutes for major traumas. We need to get that shock, the cause of the shock, reversed within 1 hour. That's the golden hour principle that we're going to talk about here. Falls can be very big considerations as well, even without LOCs, a loss of consciousness. By the way, sometimes LOC can mean level of consciousness, like altered ALOC, altered level of consciousness, and sometimes LOC means loss of consciousness. So sometimes it helps to clarify which one you're talking about. The civilian IO landmarks, we go the medial aspect of the tibial tuberosity and humerus. We don't do sternal ones. We use different IOs. We use the drills. If we were using Jamshides, those work good in the top ball of the humerus, the acetabulum, right in the top there. Or sorry, the acetabulum is in the femur. The acromion, I think that's what that joint is called. I'm not sure what the ball at the top of the humerus is called, but that's where we're going in. I have never done a humeral IO. I've only ever done the tibial ones. I've had a tibial IO administered to me though, and let me tell you, that was not the most fun experience I've had in my life.
Yeah, and I was just wondering where civilians, if you guys were going to do IOs, like what was your primary, secondary, and tertiary?
The tibia.
For us,
Tibia would be the primary.
For us, it's a humeral head
Yeah.
IO, bilateral. That's what we would do. That's where we stopped doing IV access just because you don't get it in traumatic bracing, especially when you need to set up that stuff. So we followed the IDF medics, the Israeli Defense Force, their kind of protocols, like you stop the nonsense, just get what you need, go IO and be done with it.
I've heard good things about the humeral IOs. I know that there's this, right? Especially if you go into CPR status, it's just gonna be more efficient to pump blood from the humerus to the heart than it would be to pump it from the tibia to the heart, right? We're just talking about less distance to travel. So it would be ideal if we could do humeral IOs. The reason we tend not to do humeral IOs is because of this reason. In EMS in the States, when we're dealing with IOs, we're typically dealing with cardiac arrest patients, not necessarily trauma patients. So think about the considerations when we're dealing with a CPR case. You need someone on the chest, you need someone on the airway, and you need someone on meds. If you've got all three of those people up by the top of the body, that's crowded. That's why it's helpful to have someone down by the leg for that one reason. And since most of our IOs are for CPRs, not necessarily traumas, that's the big consideration for that. Now, we can definitely do humeral IOs, but again, that same problem comes up, right? We got too many people crowded around the top of the body, and we've got all this wasted space with their legs that we could be utilizing. It's also interesting that you guys go for the humeral IOs because you're dealing with a lot of soldiers. Soldiers are younger guys in great shape. They should have really good vasculature. So IVs would actually be really helpful in those cases. Like a large bore IV.
It's so much quicker. I can do an IO in seconds as opposed to doing the whole setup for an IV. That whole setup to do an IV the way we were taught, it's supposed to be 30 seconds, but how much does it really take? I could literally just spit on your shoulder, wipe it off, call it good, and drill into your skin, be into the IO, into the bone marrow, and call it a day, and be done with it, and have the best access to IV that I could have.
Yeah, I mean, I definitely agree with you. I love the IO gun. It's always fast and it's pretty much guaranteed. It's very hard to miss those landmarks.
And thank God we got away from that. What was the sternal IO? Oh my God, that was brutal. That was killing people. It wasn't killing people, but that if you ever want to see somebody come 10 feet off the ground, just do an IO flush on the sternal IO.
Yeah. No, like I said, when I got my IO, it was not in my sternum. It was not in my humerus. It was in my tibia. And the going in felt weird. And then pushing the lidocaine in, that's when it really hurt. That was the most painful part. We don't have any pain receptors within our bones. We have baroreceptors, which are very sensitive to pressure. So it's those fluid boluses that are really going to make the difference when you're pressing these things in. So that's what's going on there. That's awesome. That's awesome. Thanks. All right. Trauma management. So like I was saying, the big priorities here are going to be on exposing them, figuring out everything you need to deal with, doing a very complete secondary, and then any sort of interventions you might need to perform. Realistically, in the EMS system, there's not a whole lot of interventions we can perform outside of like those big ones I've talked about: needle T decompression, the semi-occlusive dressings for sucking chest wounds, or flail chest, dealing with things like that. Other than those, and maybe some sort of fluid boluses, there's probably not a whole lot that we can do for these orthopedic traumas that we're dealing with, especially for these really major ones. Big considerations for us are things like, you know, trying to keep them in one piece. If they're not in one piece, gathering all the pieces together and bringing all the pieces with you. One of the first major trauma calls I went on as an EMT was a motorcyclist who shredded himself on a highway, and they asked me to go find his foot, and I never found his foot. I have no idea. I got to look for maybe like a minute, and I looked around and I looked around and I couldn't find any foot. And I came back and I was like, I can't find a foot, sorry. And they said, okay. And we drove him to the hospital without his foot. I don't know what his outcome was, but what I always remember thinking about is, did anyone go back and find the foot? And I still think about that sometimes today. I wonder, you know, did probably a coyote found the foot, but I always wondered, like, what exactly happened to that foot? Because, you know, theoretically there were cops in the area, maybe they discovered it. But my uncle works as an orthopedic surgeon. He works in a level 1 trauma hospital, and he's seen all sorts of things. He's performed hundreds and hundreds of amputations in his career. And I asked him straight up, I said, Uncle Jim, under perfect circumstances, if you had the best orthopedic surgeon team you know, surgically remove your hand and then surgically reattach your hand, would it have full function? And he said, with modern medicine, no. He said, probably not. He said, honestly, if my hand got detached, I don't think I'd even want it reattached, which was a very interesting thing to hear an orthopedic surgeon say. The moral of the story is our limbs are very complex, especially our hands. Any emergency involving the hands is a true medical emergency and requires a specialist, because our hands are basically our livelihood, no matter what you do. It doesn't matter if you're a concert pianist or if you're you know, a guy that's clicking through PowerPoint slides. You need your hands. Now, we talked about shock yesterday when I was going over the whole process, the whole physiology about what shock is. It's metabolic acidosis. It builds up and our body can't handle it. The problem isn't with our muscles handling it. The problem is with our heart handling it. So management of shock. I'm going to skip through these because we literally talked about all of this the other day. So excuse me while I get through these guys. All right. Cardiogenic shock. All right. So here we're talking more about the other types of shock. Yeah. Cardiogenic, hypovolemic, anaphylactic, neurogenic, septic, MODS, sepsis. Okay. We covered all of these topics. So management for all other types of shock. Again, the same things. I like that March idea. I think a lot of the things that we're going to read here are going to be similar in nature to those things. A big one that the NRAMT still talks about is the pneumatic anti-shock garment. I'm not really sure why, because as Phil will tell you, we don't really use that in the military even anymore. So fluid resuscitation is also a pretty big one. Now, here's the thing about fluid resuscitation. When you give a bag of normal saline or lactated ringers or D5W or whatever you give, that's going to expand their volume. It's not carrying any oxygen. It's not carrying any medicine. It's just expanding the volume. In fact, we don't even refer to these as blood products. They're just volume expanders. They're just raising the blood pressure. That's all they do. The problem is they're not necessarily going to stay in your blood for very long, because your body doesn't have any use for it. Your vasculature has no use for this. So what's it going to do? it's going to bleed out into the interstitial space. Remember, that's the spaces in between the cells. They're wet with fluid to help transfer electrolytes. And that's where all that's going to go. After 1 hour, half of it is going to go into the interstitial space, no longer in the vasculature. If we can't get peripheral lines, we go IO. We can also go IO in acute status patients. Now, with trauma patients, if I've got someone with good vasculature, I personally will go for IVs, because I believe that a good 16 gauge IV is always going to be the fastest way to get medicines on board. Now, compared to like a humeral IO or a tibial IO, we're probably talking a couple seconds difference, but why not get the best thing you can get? Plus, it's good to have a very large bore IV in order to give fluids as fast as you can. Now, that being said, most modern IO needles are 15 gauge, meaning that we can give things pretty well. The problem is the resistance that they're going to be facing. It's hard to give a fluid bolus via an IO. If you guys have ever tried to give a fluid bolus via an IO, obviously to an unconscious patient, you'll know that we definitely need a pressure bag on those saline bags in order to get that stuff in at all. So that's one of the things that goes for that. So we have a couple other possible fluid things. We have some like packed red blood cell products, and then hemoglobin-based oxygen carrying solutions. These differ because these can transport O2. This would be better, but pretty hefty price tags associated with these things. So don't expect them to become mainstream anytime soon, unfortunately. Now, is the military going to be utilizing this? Oh yeah, probably. Well, the Air Force, at least. The Air Force is where a lot of the really good resources go. But again, a lot of this is going to be kind of testing and then theoretical until we get through to it. Where do we get these hemoglobin? From human blood or bovine blood. Cow blood and pig blood is actually very close to human blood. Pig organs are very similar. It's just interesting. I mean, kind of makes sense when you look at some people, but what's ultimately amazing about this is, like I was saying, the difference between one mammal species and another is slight. All right. We share 99% of our DNA with chimpanzees. We also share 99% of our DNA with bananas. So, you know, ultimately things are very close, but it's that 1% of difference that makes all the difference. Maybe it's not 99% of our DNA with bananas, but it's honestly, it's like 90% of our DNA with bananas. That's just one of my favorite facts. Here's a couple of the products: Polyheme, Hemopure. I've never gotten to utilize any of these. If you guys work in the hospital or Phil, if you in the military have used any of these, I'd like to hear about them, but I don't have any experience working with any of these products, or even with like blood packs for that matter. I know that blood packs definitely help. The problem, as we talked about, were those transfusion related acute lung injuries, TRALI. And remember, that can essentially cause, within about 6 hours, this massive pulmonary edema. Now let's go over the pneumatic anti-shock garment. For those of you unfamiliar with the pneumatic anti-shock garment, here's what it is. It's basically a pair of pants that you pull over your legs, and then you inflate it with air to squeeze the blood towards your core. The same effect as shunting, similar to the way that we used to place patients on supine positioning and then elevate their feet and lower their head. We called that Trendelenburg positioning. We don't really do that much anymore. It's more of a specialized thing that they might do in ERs. It's generally contraindicated in the EMS fields because there is always a potential for that to cause other harm. Now, the idea behind these pneumatic anti-shock garments is solid. It shunts blood back towards the core of the body where it needs to be in order to keep you alive and keep you conscious. As Phil was pointing out, that if the patient is altered or unconscious, this is a major cause for concern, right? In movies, we tend to downplay the severity of concussions and being unconscious for long periods of time. That's not good for you, okay? Don't knock people out and then let them lay there for a couple hours without getting any medical treatment. That's how people die, okay? They don't wake up in a trunk 3 hours later and feel fine. Every time that happens in a movie, it takes me out of it. Hypoperfusion with unstable pelvis or bilateral lower extremity fractures. Let me tell you guys a story about me. I used to play basketball obviously I'm a giant tall guy. I played a little bit of basketball in college, not like I played college ball. Okay. I played on an intramural team when I was in college. I was not good enough to be a pro baller. Don't worry. But when I was playing, I went to go take a charge, and someone came in with their knee right in the center of my big, long femur, and it hurt like a mother. Probably one of the worst pains I've ever felt. Did it break my leg in half? No, of course not. I got strong bones. I drank my milk. But it gave me the tiniest little hairline fracture in my femur. I never needed a cast. I didn't even use crutches. The doctor told me I wouldn't need crutches. He told me I could walk on it. He might have been wrong about that, but what are you going to do? But here's what happened. It wasn't so much the bone where the damage came from. It was the arterial ruptures that happened with it, because my leg swelled up. My thigh became about, I would say, 3 times the diameter it normally was. I was wearing basketball shorts, and my basketball shorts were tight around the leg that was affected. My leg swelled up huge. This is because your quadriceps are big, big muscles. Even if you've been skipping leg day, those are big, big muscles, and they can hold a lot of blood. A lot of blood can leak into there. You know what else can hold a lot of blood? Your pelvis. Between both of your thighs and your pelvis, you could hold 4 to 5 liters of blood in the interstitial space before they're filled up. By the way, you're also at increased risk of compartment syndrome because of this. Is it extremely likely? No. In fact, I didn't deal with the compartment syndrome aspect of this. The blood was able to drain out over time, and I didn't have any serious repercussions from it. Probably just got lucky, though. So that should let you know just how much blood can be in there. Now, when we go give blood, I think they let you give 1 liter at a time. I believe that's, or maybe it's a quart. I honestly don't. I think 1 liter and a quarter, I mean, pretty much about the same amount of liquid, if I'm understanding. One's like 1.6 or 1.06 or something like that. The other, it's essentially 1 quart and 1 liter, about the same for the purposes of me teaching you guys. You can give 1 liter. You notice after you give blood, they tell you you can't operate heavy machinery. Don't be careful working out. They make you sit there, drink some water, eat some cookies before they let you leave. The reason for this is because you've just given up some blood. Your blood sugar will be a little bit low because you've just lost essentially 1/7 of your blood sugar, right? You've also just lost 1/7 of your oxygen transporting ability. You've lost 1/7 of your body's ability to deal with shock. So your brain is not getting the full amount of oxygen. You're going to be a little bit loopy, a little bit tired, a little bit lethargic for probably about a day. You're building red blood cells all the time, all the time. Your body immediately recognizes that you're in shock, right? They're definitely a compensated shock though. Your heart rate has gone up. Your blood pressure has stayed about the same, but with your heart rate going up, that's because you've compensated in that way. So if you've ever given blood, then you've experienced this. Pulmonary edema is the only absolute contraindication for these pneumatic anti-shock garments. Remember, pulmonary edema is fluid buildup in the lungs. Why is that a problem? Well, think about it. If we're decreasing the ability of the legs to accept new blood flow, where is that pressure going to build up in? The lungs, or sorry, the left side of the heart. Where is it going to build up after that? The lungs. They already have pulmonary edema. You're just going to make it worse. This is a big problem for these pneumatic anti-shock garments. In fact, I would say this, combined with the fact that they're expensive, and trauma hospitals are definitely in the mindset of cut it all off, doesn't matter how expensive it looks. That's why we don't carry these things. Not because they don't work. Although, like I said, the evidence just wasn't there to support them. We also don't want to do it for heart attacks, pulmonary edema, uncontrolled bleeding outside the confines of the pants. So abdominal bleeding, chest wounds, maybe even upper extremities, if it was uncontrolled. Ideally, it would be controlled at this point. If you had time to get these pants on someone, then you should probably have had time to deal with the bleeding in their other extremities. All right, so we talked about those. Volume expanders. So how do we deal with each one? Hypovolemic shock, volume expanders, or hemoglobin-based oxygen carriers. Cardiogenic shock, volume expanders, vasopressors. Distributive shock, volume expanders, vasopressors, and potentially pneumatic anti-shock garments. Obstructive shock, volume expanders. Spinal shock, volume expanders. Transport considerations, rapid transport to a trauma center. All right, tourniquet protocol. Now, this one I'd definitely like to hear from you, Phil, because you've definitely put on more tourniquets than the rest of us combined. I have used literally 2 tourniquets in my entire career. And one time I really don't think we needed it, honestly. And the other time, yeah, absolutely we needed it. We had a clean amputation and boop, that definitely did the trick. Now, what's interesting about tourniquet protocol is that NREMT still requires high and tight. And I know the military generally likes to go high and tight, but here's the consideration, you guys, and this is for everybody, not just for Phil. Obviously, Phil knows tourniquets better than me anyways, but here's what you guys need to know about tourniquets. When I was first learning about tourniquets, I was told you should never place tourniquets on the distal extremities, meaning the forearm or the shin. The reason being that those are dual bone structures. Remember, it's the radius and ulna in your arm or the tibia and fibula in the leg. The reason for this that was told to me by a paramedic whom I trusted is because the artery runs along the big bone, the humerus or the femur, but then it runs between those 2 bones in the distal extremities. And so in order to get a tourniquet on tight enough, you might actually break one of those bones before you stop the circulation. This is what he told me, and I believed it for years until I actually looked at anatomical landmarks and I realized that's not true. Arteries do not run in between the bones in your arms or in your legs. You guys probably know that's true because we take blood pressures on the bicep. But what do you do when you get a very obese bariatric patient whom the bicep will not work? You can't get the blood pressure cuff around their bicep. What do? You move that blood pressure cuff on down to their forearm and you get the pressure there. Is that just as accurate? No, it's usually going to be about 10 points higher systolic than it would have been otherwise. The reason for that is partially because those 2 bones do make it slightly more difficult to form a good seal on that artery. And here's why. The point of those 2 bone structures is to rotate, supinate and pronate your hands or rotate your ankle from left to right. It's more pronounced in your arm than it is in your legs, but the ulna is a very curved bone. And so in order for you to do that supination and pronation of your wrist, it curves around, and this will put everything into a different orientation. When there's only 1 bone and 1 artery in your upper arm, it's easy. But remember, at the cubital, that brachial artery separates into a radial and an ulnar artery. And then it separates into other arteries and other arterioles in your hand and your wrist as things get more and more complex. So can you put a tourniquet? Like let's say someone's hand is cut off right at the wrist and it's spewing blood uncontrolled. Where would be the best place to place the tourniquet? As according to NREMT, around the bicep, high and tight. Never on an elbow. That goes without saying, all right? Whether you want to place it on the dual bone structure or on the single bone structure is kind of up to you, but you don't want to place it around a joint because then you definitely won't get the right seal. Now, there's arguments to be made on both sides. Can you get a better seal from the bicep? Yeah, of course. Can you get enough of a seal on the forearm? Absolutely. Especially with some sort of padding or something just to stop the bleeding. But there's one more consideration here. When we're placing tourniquets, we're essentially causing compartment syndrome in that extremity, meaning that when we eventually do pull that tourniquet off, we're going to be releasing a bunch of old toxin-filled blood, which is going to go straight to the heart right away. So whenever we're dealing with compartment syndrome, remember that we need to have large bore access established on this patient. And just prior to the release, we need to flush in a bunch of sodium bicarb, a bunch of calcium chloride, and a bunch of fluids to try to keep that rush of acidic metabolic acidosis blood from rushing back to the heart and causing cardiac dysrhythmias. So there's quite a few considerations. I don't want to get you guys too confused on what the best thing to do with a tourniquet is. So here's what you need to know for the NREMT: high and tight. Now, that being said, Phil, If you had someone whose hand was amputated right at the wrist, would you want to place the tourniquet high and tight, or are you placing it as close to the site as you can?
No, I'm going to go high and tight just because it's simple, it's easy, it's 100% solution 100% of the time. I'm not going to mess around with these two bone structures between the the lower extremities. Everybody's forearms are different, but that little piece between the bicep and the shoulder, that little, what we like to show off, the beach muscle right there, that is what God made tourniquets for. That right there, it stops everything. It's as close as your brachial artery is going to be to the surface. So why not do something that's going to be 100% of a solution 100% of the time? Go high and tight right there. It shuts it off. I understand the ischemic value that the PTHLS book talks about for tissue ischemia, but it's relative. Everybody lives in the civilian world so close to a trauma hospital that's a non-issue. It's more of an issue when you have to sit on it for 6 hours. That's where that compartment syndrome topic starts to come up in your minds. Like, you want to start to actually alleviate that tourniquet and convert it. So that's my 2 cents. Sorry.
All right, there you go, guys. I would go with what Phil said there. And that, by the way, that's also what the NREMT says. So there's a couple considerations for you guys, but yeah, what Phil's talking about is probably the best place to place a tourniquet is if you're following your biceps, at the top of the bicep, before you get to the deltoid of the muscles of the shoulder, there's a nice little crease in there. And he thinks that's where he's talking about for placing that tourniquet. And there's another consideration, which I had not considered, which is that is where the brachial artery is going to be the closest to the surface as possible. So I would still recommend doing it that way. And there was another thing he mentioned, which is super important. In EMS, we're probably at most 30 minutes, maybe an hour if you work very rural from a level 1 trauma center. If you're really that far, you should be considering calling in for a helicopter transport anyways. So with that consideration, yeah, absolutely. Now, if you're in a military base overseas and you get hurt in the war zone, you get lifted out to the base, then you get lifted to the hospital, which is probably in one country over. Yeah, it might be 6 hours before you see a trauma surgeon. Slightly different considerations. But until you guys go into war, keep doing it this way. Thank you, Phil. Here we go. Developments on the battlefield have brought forth an understanding of the value of providing tourniquets as a last resort in the event of severe bleeding. Now, realistically, guys, most bleeding can still be controlled with just direct pressure, okay? The only thing that really you're going to need tourniquets for are uncontrolled arterial hemorrhages, which again, really only come up in amputations. And by the way, not every amputation is going to bleed thoroughly. I've seen people with amputated fingers and there's no need for a tourniquet. I've seen people with I saw a guy once with an amputated foot and it was like barely dripping blood, barely. One of the weirder things I've seen. Now, did he have other problems going on that were probably affecting his circulation? Yeah, he probably had some peripheral neuropathy, probably had some issues going on there. He'd had reduced blood flow to those areas for a while. They just didn't bleed as much. If you don't need to control with a tourniquet, we shouldn't use a tourniquet. Tourniquets can be dangerous because of what Phil and I were talking about, compartment syndrome buildup. Very much of real consideration. However, it's going to take a long time for skeletal muscle to die. Can skeletal muscle die? Absolutely. It's a muscle. It's alive. It can die. How long does it take to die? Depending on the muscle, probably about 3 or 4 hours minimum. So we can leave tourniquets on for extended periods of time. Now, it's really important to understand how to make tourniquets. Even if you don't have one of these, I don't know which generation of cat tourniquets we're up to right now. I don't know, Phil, if you know. Last one I used was, I think, a Cat 6. I don't know if there's one more advanced than that now. But those cat tourniquets are the combat application tourniquets. I think we're going to see a picture of one here in a second. They're the most common ones. They're those black or orange ones. And they have to be at least an inch wide, all right? We don't want something like a string to do a tourniquet. That's not efficient. We want something that's 1.5 inches wide so it can compress it without cutting it, if that makes sense. So we need a nice wide band. This is why a belt works better as a tourniquet than, like, let's say, a string. You know, that's the best thing I can think of. Hemostatic agents can be used to control bleeding. This is really nice. We have hemostatic agents here in San Diego, and I got to use one for the first time, and I thought it worked great. Now, what are hemostatic agents? There are things that help promote clotting. So the idea is to clot the wound site to stop the bleeding at the site, used sometimes in conjunction with tourniquets, sometimes in lieu of tourniquets. What's the idea behind this? We want to pack it in there. There are chemical agents on these gauze strips, which are derived from a type of shrimp or a type of shellfish. I'm not 100% sure. Some of them are derived from that, and some of them are derived from other plant or animal products. Doesn't mean that like they just squeeze a bunch of shrimp juice onto that thing and then they plug it in there. No, what they do is they study the things that help shrimp clot their bloods or their blood clots, and then we utilize those same syntheses in order to create these hemostatic gauzes. So the idea is that you take this gauze roll, and it's kind of just like an ace bandage or something. You tie a little knot in the end and you jam that into the bullet hole or the bullet wound. And then you keep packing it in, and then you wrap it around the outside of it, and it's going to help the clotting process. This is the one we use in San Diego. It doesn't look like this, but it's the same brand, Quick Clot. I think it works really good. Or sorry, I keep saying that, and that's improper English. It works very well. We've gone back and forth on tourniquets. I'm sure Phil has seen this before too, that we'll swear by tourniquets, and then we'll say, no, they're not good. And then we'll swear by them, and then we'll go back on them. And then for a little while, people were talking about using tampons, and that was never a good idea. Don't use tampons, okay? If someone's got a bullet hole and they're bleeding really badly from it, apply a tourniquet. If it's in their chest and you can't apply a tourniquet, just apply direct pressure, all right? No, never stick a tampon inside anyone. Well, you guys know what I mean.
Exactly.
As a trauma.
Exactly the thing. Thank you.
I mean, I need to preface that.
And here's the crazy thing. We had special operators that worked in these groups like Delta and CAG and all these guys. Like they were carrying these things in their chest rigs. And you look at them like, what are you guys doing? You're not putting that stuff in anybody. So, yeah, even the high-speed guys were using that stuff. Ridiculous. We corrected them.
You know, I think some of those guys maybe know what they're talking about. But realistically, I carried a ton of gear when I was brand new. I carried a ton. I actually carried a little go bag on me. I was little Ricky Rescue. I had my everything on me. As I got more advanced, I started stripping that down, and that go bag became just a little fanny pack that had, had a granola bar in there for me and an IV start kit and then a Narcan kit. And that's all I carried. As I became a more competent and a more comfortable paramedic, I started carrying even less. Now what I carry on me is a flashlight, a multi-tool, my protocol book, and at least 2 extra pairs of gloves, because you can never have too many pairs of gloves. Those are the big things you need to have on you. Everything else I can get from my bags. I'm carrying those bags with me on every single call, which I should point out to you guys is a definite consideration. Every single call you go on, you're bringing all your gear. You're bringing your airway bag. You're bringing your life pack or your Zoll, your monitor, and then you're bringing your trauma bag on every single call. And then you're also bringing your medication box. All of those on every call. It doesn't matter. It's abdominal pain for 1 week. All we need is a life pack. Let's just get a set of vitals and we'll bring them back down. No. The one time you don't bring it is going to be the one time it ends up being a CPR. I saw it happen once. It wasn't me, but it was, we showed up on scene with the fire engine, and all the firefighters just jumped out of the engine, just ran right in like a bunch of heroes without a single piece of gear among all 4 of them. Me and my EMT partner load up everything on the gurney. We get in there and we find 3 guys standing around frantically while 1 person's pumping on a chest. You better believe that got audited. You can't just go run in there without your stuff. Now, it's not to say that you shouldn't carry gear, because I've definitely wished I had things on me and I didn't. But it's helpful. Everything I carry on me now is the stuff that I think I need. Now, you might differ depending on where you get it. Yeah, the boot's supposed to bring it, but a good paramedic isn't going to rely on anyone else to make sure he's got all his gear in order. That's, I think, a big thing, right? A good paramedic is going to check every single day to make sure that at least the major things he needs to know about are there. I make sure my oxygen tanks are filled. I make sure my intubation kit's ready to go. I make sure all my drugs are set. I'm set and golden. I make sure the life pack batteries are charged, and I'm golden. And then I'll do this little thing. I'll make a little IV start kit burrito is what I call it, where I'll take like a towel or something, because the towel is the thing you want to put down your leg. Because if you've done enough IVs, then you've bled out a few patients, right? We've all done it. So it's always good to have a towel just in case they bleed. And then inside that towel, I'd wrap up the, what's it called? The cover. I can't think of the name of it. The cover for once you get the IV in there. An 18 gauge and a 16 gauge IV and a 20 gauge IV. A couple alcohol prep pads, at least 2, and some gauze. And then I just wrap the whole thing up in a tourniquet. It's my little IV start burrito kit that I had ready to go. And that was nice because if we jump in the back of the ambulance with a critical patient, you've got maybe 3 other people with you working on him. I could just jump over into the seat where I'm out of the way and then open it up, and I've got everything I need to start an IV kit, at least 1 or 2 attempts, right? Because I've got a couple different sized IVs, depending on if it's a major trauma, depending on if I just need access for medications. If you put in a minute of prep time, it saves you a minute of scramble time later. And realistically, it's going to save you more than a minute of scramble time, because when you get into the middle of things, it's harder to remember everything you're supposed to remember. A really concrete example of this came from one of the teachers who taught me how to be a paramedic. He was going over EKGs, just like we were the other day. And he was saying, you know, ways to remember stuff, ways to remember how to treat stuff. And then he made a joke. He's like, "You're going to remember this in 5 minutes?" And we were like, "Yeah." He's like, "I'm going to call you at 2 a.m. this morning. Are you going to remember it then?" And we're like, well, I mean, maybe. He's like, "I'm just kidding. I'm not going to call you at 2 a.m. But you're going to get this call at 2 a.m. And are you going to remember it then?" I remember that comment because it put things in perspective for me. You are going to get this call at 2 a.m. Are you going to remember this stuff when it matters? Here in the United States, we have this big thing we like to make fun of firefighters, right? It's all good-natured ribbing. We love our firefighters. But we like to say this, this concept of making something firefighter-proof. The idea being that it needs to be so simple that even a firefighter could operate it. Now, here's what we really mean by that. It needs to be so simple that you can operate it in an emergency situation. When S hits the fan, are you going to be able to react calmly to these situations? And that's what the general hope is. So that's the tourniquet protocol. As far as NREMT says, do not use distal to the elbow or knee. This is not true. Ignore this portion of it. The arteries do not run between them. But this other part is true. This compressing is difficult. We can see this from taking a blood pressure on the forearm. It's higher, meaning it takes higher amounts of pressure, meaning it's going to cause more damage overall. Because remember, those compression of the end of an area causes damage. Here's the cat tourniquet right here. Looks like one of the older generations. Do the newer generations look any different? No. The only thing that changes from generation to generation is maybe the materials they're made out of, maybe like the quality of the Velcro strips, you know, the quality of the buckles, things like that. Generally, they're just getting a little stronger, more lightweight, more comfortable. I mean, they're not comfortable, but more comfortable. More durable, yeah, that's a good way of putting it. Even so, these are single-use tools. These need to be thrown out right away. I've got 2 tourniquets in a go bag in my trunk, just in case I ever roll up onto something. You know what else is useful to have in a go bag in your trunk? Is a BVM. A BVM is something that can definitely make a difference in a lot of these cases. And it's something that you're not going to, I don't want to put my mouth up against anybody else's mouth to do CPR in my life. Okay. Hard pass on from me. Closest I've ever gotten to that is administering one of those face masks. Here's some pretty severe tourniquet injuries, not tourniquet injuries, but injuries requiring tourniquets. You can see where they've placed them here. Now, one advantage to placing one here is in case you don't get a full occlusure of the vein, or sorry, of the artery, you can place another one higher and tighter, right? So you can place multiple tourniquets on either one. Oh, yeah, it looks like left side didn't really work out, honestly. I mean, I don't know. I don't have any sort of idea what these are from. These look like military application. Those look like military tourniquets to me. No, wait, that's not. That looks like a friggin' stick and rocks. Actually, never mind. Yeah, it's definitely like made out of sticks. I never really noticed that before. That's interesting. Who knows if that guy lived or died? Now, will this be as effective? No, but will this slow the flow of blood? Yes. And will that slowing of the flow of blood potentially enable the clotting cascade to take effect? Possibly. It really depends on the health status, medications, other things going on board. They showed you that exact photo in CLS. All right. Well, I can see that guy not making it. But I've also seen people with injuries just that bad who did make it. But that's interesting that you've seen that photo before. Now, soft tissue injuries and burns. I want to cover these two things specifically. The rest of trauma, I'm going to be honest with you guys. Most of trauma is not that big of a consideration as far as the things you need to be doing, right? Because like I'm saying, in the EMS and NREMT considerations, trauma surgeons are going to be dealing with they're going to be dealing with fixing trauma. Our goal is stabilization of trauma. Okay. I'm not the handyman. I'm the roll of duct tape and WD-40. Okay. I am not the repairman. That's important for you guys to remember. We're duct tape. We work really well for a little bit of time, but ultimately we need other things. So one important thing I want to talk to you guys about soft tissue injury is this. It's simple, okay? Soft tissue injury are lacerations, abrasions, punctures, wounds, small injuries, okay? It could be things like stabbings, might even be small caliber gunshot wounds, maybe even large caliber gunshot wounds, but most of these are generally able to be dealt with fairly simply. So, burns. I'll talk about burns first and foremost because this is the big one. So, here's how you guys need to think about burns. Burns are going to go through 4 phases that we need to deal with. There's an emergent phase, a fluid shift phase, hypermetabolic phase, and then finally resolution. So here are the major considerations for burns. And when I'm talking about burns, I'm not talking about burns on less than 10% of our body. I'm talking about 2nd and 3rd degree burns covering huge amounts of the body. Do you have a question, Nathan? Sorry. So you can type out if you have a question, but right now I'm going to keep going on. So here's what I want you guys to think about when we're talking about burns. Oh, he was talking about the photos from the tourniquet one. These ones. He said these were from the slides that he's also a teacher and he teaches some of these trauma classes. So they use some of these same slides to show tourniquet failure. That's what he was talking about. So burns. All right. So here's what I want you guys to know about burns because it pays to pay attention to what a burn is doing to our body. All right. And here's the ultimate bottom line. It's ruining your skin. And that's the problem. Okay. Your skin is your spacesuit. Your skin is your first line defense of your immune system. Your skin helps maintain heat. Your skin protects you. And your skin is the biggest organ in your body. And now your skin is compromised. Okay. Let's take, for example, a large body surface area burn. The worst burn I ran on was a guy working in a meth house. Methamphetamine is a very explosive drug. Okay. And people working in meth houses usually are not taking good precautions with their fire safety. All right. The fire marshals very rarely approve of meth houses. Very rarely. So he had 2nd and 3rd degree burns on over 60% of his body. Let's say it's closer to 75% of his body. So what's going on with him? The first and foremost thing is his skin is ruined. And the very first thing we need to be aware of is how that's going to affect his thermal regulation. Okay, because remember, your skin is where you are storing and keeping your heat, and we need to keep warm on the inside. We talk about the important thing blood transfers. It transfers oxygen, it transfers sugar. It also transfers some nutrients, it transfers medications, blah, blah, blah. But there's one thing we don't really talk about with what blood transfers, and this is why it was really nice for Phil to bring up the March protocols, is that last one, the H, is hypothermia. Your skin, your blood transports heat. You thermoregulate through your blood. How? If you're trying to cool off, we expand the blood vessels near the surface of our skin to bring that blood closer to the surface of the skin. If you touch someone and they're warm, they're losing that heat off to the environment through convection, right? So now that our skin is compromised and ruined, our spacesuit has been ripped open, all that heat is just going to be lost to the environment so much faster. And here's the other part of that problem. Our skin is damaged. How does your body deal with damage? Histamine release makes everything more leaky, and it brings blood to the area. So now we have blood flooding to the surface of the skin, being lost to the ambient environment. The number one thing that's going to kill someone when they get out of being burned is hypothermia. Hypothermia is deadly in shock. Blankets are your friend. Blankets are your patient's friend, okay? And not wet blankets. We used to wrap people up in a big wet towel or something like that after they'd been burned because it feels great. The same thing about running your hand underneath like a faucet when you burn it. It feels good, right? It feels really great, and it will feel great to them too. You can totally do that for small burns, right? Less than 5% of the surface area, 10% of the surface area. Yeah, you can go ahead and make sure put a wet saline-soaked bandage on there. But be aware that you're going to be losing a lot of heat. What does HPMK stand for? I'm not familiar with that.
Oh, they're a hypothermia management kit. So they come with several layers. Your basically your outer layer, inner layer, which is kind of like a blanket, and then your heating sources and stuff like that. So you're able to titrate heat inside and out, so you don't cook your patient, but you can manage it.
Excellent. Yeah, no, I wish we use things like that here, but again, we're also talking about quicker turnover times. So
exactly.
It wouldn't always make sense in the case of like rural EMS, or I'm sorry, with like metropolitan EMS, maybe in more rural things. Anyways, you still want to make sure that we're still thermoregulating for our patients because they no longer have the ability to keep in their own body heat. And keeping in our body heat is extremely important. So we're worried about reflexive hypothermia first and foremost. Now, what else is going to happen? That fluid shift, right? Blood is flooding to the area to try to heal it. And it will eventually do a fairly good job of healing it. I mean, all things considered. But it's going to take a lot of time, and a lot of fluid is flowing out of there. So the next thing we're worried about is all that fluid shift. So we're losing blood from our vasculature. So we need to get fluid on board. You guys might remember the Parkland fluid formula for burns, where we take, I think it's 4 milliliters times the patient's weight in kilograms times total amount of body surface area burn, and then we come up with an amount of liquid. It usually ends up being, let's say, 3 to 4 liters. We want to give half of that within the first 8 hours, and then space out the other half of it over the next 16. Again, remember, blood doesn't stay in our vasculature very long, fluid, volume expanders don't stay in our vasculature very long. They flood into the interstitial space, and they're also not transporting oxygen, not transporting medications, they are transporting some heat, but not as much, okay? In fact, the administration of cool fluids interior to the body will actually cool it down a little bit. Sometimes when I was working in Arizona, we would have actually IV warmers to help warm up the saline so that we can get warm saline on board the person. That's a good way to warm people up. The next consideration is going to be the patient healing themselves. And remember, their spacesuit is now ruined, so they're very prone to infection. The first line of our immune system is compromised. Infection is very likely at this stage. It takes a long time watching a patient who's had severe burns to make sure that they're not going to get burned any further. Now, there's one more consideration here. If we're dealing with third-degree burns, we have muscle involvement. What happens when the muscle dies? The myoglobin breaks down. We learned about this when we were talking about cardiac lab enzymes. So the myoglobin is broken down. That myoglobin is now floating in the bloodstream and needs to be processed by the kidneys so it can be eliminated. We call this rhabdomyolysis. The body does not do a good job breaking down myoglobin because it shouldn't ever have to break down myoglobin, right? We should never be undergoing that much stress. We are during extreme third-degree burns over large amounts of our body. So the chance that their kidneys are going to be affected is also very high, which is also part of the reason why we're flushing that system with fluids, flushing it out. Now, we also run the risk when all of this fluid going on board for dilution anemia. If we're giving too much volume expanders, but there's just not enough red blood cells, they're going to become anemic, not because they don't have enough iron, just because the amount of iron is too low compared to the amount of fluid within there. This is also going to, as the body's healing, it burns through more energy. Anytime we're healing or scarring or dealing with internal injuries, our metabolism spikes. This is just the way things work out. It makes sense. More work is being done, more calories are being burned. But we're talking an extensive amount of calories. If someone's had burns over a good deal of their body, they can go through as many as 10,000 calories a day. All right? I'm not making that number up. Them and Michael Phelps are eating stacks of a dozen pancakes every single morning. Obviously, they're not really going to be eating probably, but they still need to get those nutrients on board. A huge caloric need for these patients. So just something to keep in mind. Those are the big things that are happening with burns. And I think it's important for you guys to know that so you can understand why this is such a severe potential problem. All right. Again, there it is. The patient in this stage, the hypermetabolic, may need up to 10,000 calories a day because of their hypermetabolic state. Finally, there's the resolution phase, when the body begins to form scar tissue and continues the process of mending itself. The effects of these 4 stages of burn recovery are important in any patient with burns that covers 20 to 25% minimum. All right. We're going to skip through this stuff because that's not so important. Now, the levels of burns, I'm sure you guys know. First-degree burn, just a regular sunburn. We've probably all had this at one point in our lives. Once we form blister formation, it becomes a second-degree burn. Anytime those blisters are formed. This is a pretty extreme second-degree burn here. It doesn't necessarily have to be that bad. This one is blisters. Perhaps this has happened to you before too. One patient I had was a guy that was at a nudist colony, and he got second-degree burns over about 80% of his body. He also entered into rhabdomyolysis. He was probably 65. I don't think he probably survived that, honestly. Rhabdomyolysis is so deadly if you're over 60. It's so much more deadly. Finally, there's third-degree burns. Not finally, sorry. Next stage up would be third-degree burns. This is when we have inflexible, tight, maybe complete lack of sensation or pain, black or white, waxy, charred appearance. It can appear in quite a few different ways. If you can't differentiate if it's second or third degree burn, classify it as the third degree burn. This one would be pretty clearly third degree burn. One other thing that you're going to see, or you can definitely see that you might not think about, this guy looks like he was wearing shoes when this happened. I've seen something like this before. Guys wearing shorts, they get their legs badly burned like this. Look, there's also an escherotomy performed on the inside of his leg there. They had to cut it open because compartment syndrome. Think about this, guys. The surface of your skin is burned. If this is only first, second, maybe a light third degree, the arteries might not be affected. The veins are definitely affected. That means we're going to have a hard time returning blood to the heart. This is going to cause compartment syndrome. This is why we need to perform things like this escherotomy, or cutting it open to release that pressure and release the ischemia. Now, something that they don't really tell you for third degree burns, but you will definitely notice, is the feet, expect them to be like wet with like drips not necessarily of sweat, but it's edema. It's water, almost like a weeping edema. If you've ever seen that on patients that have like really terrible peripheral neuropathies or really severe pedal edemas, they might even have something called a weeping edema. So sometimes we'll see actually the fluid, the plasma leaking out of the skin distal to the injuries. I've seen that before too. That's another third-degree burn. Again, look at that black charred appearance. There's a third-degree electrical burn. Again, another escherotomy performed. They have to cut it open. Escherotomies are not subtle procedures, okay? There's also one more type of burn that we're not going over here, which is a fourth-degree burn. Fourth-degree burn means the bone is now affected and the bone has been burned through. The bone might not be dead, but the bone is severely compromised. Why is this important? Because that's where we store calcium. That's where we produce red blood cells. Now, this whole phase of us healing ourselves has been compromised even further. Most likely, they're going to have the limb removed at that point. I mean, at this point, I don't expect him to keep that hand, honestly. It depends. It honestly depends on quite a few factors. I am not an orthopedic surgeon. Chemical burns, very few percent of burn injuries, but 30% of all burn deaths. So they can be very deadly. If we don't know what the chemical is, we need to get the patient out of their clothes ASAP, including their socks and shoes, because very likely they can pool in their socks and shoes. We need to get out of them. Now, realistically, if you're responding to a chemical burn or a chemical emergency or a hazmat emergency, you're going to be responding with hazmat specialists. Every single city department needs to have at least one hazmat specialist team. It's part of the ISO requirements for a lot of fire departments. Outside of that, any business that's operating with hazardous materials will usually have things like safety showers and neutralizing agents like vinegars or whatever they might need, and eye wash stations, showering stations. They'll have a whole list of procedures in place. And by the time you get there, they should have run through them already. Now, that's the case if this is like an industrial site. I just mentioned showing up at a meth house. Do you think meth houses have eye showers? Do you think meth houses have chemical data and neutralizing agents on hand? No. Meth houses have a lot of meth and also a lot of meth heads in them. So don't expect this every single time, but in general, if you're responding to a commercial environment, it should be handled to at least some extent prior to your arrival. Now, I wanted to cover, so one more thing here is that's for chemical burns. What if we have a powdery substance? We want to try to brush it off prior to flushing it out. Chemical burns, we want to try to flush it out with as much saline as possible. Sometimes things can be reactive with water, so we try to go with saline over water. For example, lye. I'm sure you guys have all seen Fight Club. The first rule of Fight Club is to be fun and be yourself and have fun, right? Second rule of Fight Club is, I can't remember all the rules of Fight Club. That's the only one I really remember. I don't think I'm supposed to talk about the rest. But you guys might remember that scene where he kisses his hand, letting some of the water from his lips form just a slight wetness on the guy's back of his hand, and then he pours lye on it. Lye is used to make soap. Lye is obviously not reactive, but that's when it's combined with other things. Lye doesn't react on its own, doesn't burn you, but lye does react with water. Some agents react with water. Usually these things need to be neutralized by pouring vinegar on them, not water. Why vinegar? Because vinegar is extremely alkalotic and it will neutralize it. Now, I'm not a chemist. I don't know everything that interacts with everything. And if you don't have vinegar, which anyone working on an ambulance does not have vinegar, then we're just going to have to flush it with saline. If it's a dry chemical, we brush it off and then we flush it off. To neutralize or not, general rule of thumb is no, unless you know what you're dealing with and you have it on hand. For alkali exposures, different than acid burns. Acid burns are very skin deep. Alkalis or alkalotic substances, they will cause something called liquefaction necrosis. They will sink in, deep penetrating injury, dehydrate the tissues, and cause thrombosis, which is the fatty buildup of and clotting buildup in the blood vessels. Little pain, usually cleaners, but they're deep, extremely damaging. There's alkali burns, as opposed to acid burns, which generally are not as deep, but can be a little more profound in their appearance. I think it's despicable, people that throw acid in people's faces. That's one of the most despicable things you could do to someone. Flush with copious amounts of water. Alkalis may require several hours of irrigation. I don't know if you saw this one photo back here, but there's like this tube going in and out of his foot. I believe that is trying to provide a lot of fluid bolus. I'm not actually sure 100% what's going on there. It's a weird one. But my thought is that they're trying to flush the system out. Electrical burns depend largely on, yeah, it might be a drain as well. Electrical burns depend largely on the amount of electricity and the type of current, whether it's alternating current or a direct current. Both of them are deadly. It really depends on the amount of joules. Now there's joules, amps, watts, lots of different ways we have to differentiate electricity. I am not an electrician. I do not understand it. I understand joules the best of anything because joules is something I work directly with, right, to defibrillate patients. However, when we're pacing, we use milliamps. So again, what's the difference? I don't friggin' know. Go ask an electrician. Don't get burned is the moral of the story. Don't get struck by lightning either. You know what's very interesting is once you get struck by lightning, you are more likely to get struck by lightning again. Something happens where some people, I think, just have slightly more electromagnetism and they're slightly more likely to be hit. I have only known 2 people that have been struck by lightning, and both of them have been struck by lightning twice. Now, I also think if you get struck by lightning once, clearly you're not making the best decisions, and clearly getting struck by lightning will do nothing for your decision-making process. 0.001 what? Joule equals 1 milliamp? Or 1 watt? I think it's joules you're going for. Wait. Oh, well, yeah, obviously 1 milliamp is 1/1000th or 1/100, yeah, 1/1000th of an amp. But I don't know how an amp compares to a joule. That's something I've never really understood. There's a bad electrical burn. Don't bite down on sockets. More electrical burns. More electrical burns. There's not a whole lot we can do other than providing care for the patient that's been struck by lightning or struck by large doses of electricity. Now, I've gone on quite a few patients that have been tased, and quite a few patients have been pepper sprayed. Not always a lot of fun. I think tomorrow we're going to go over patients that have been pepper sprayed and how you deal with those. Spoiler alert, saline. Not water, saline. All right. Now, rule of 9s, this is also going to be something you're going to see on the test. This is pretty efficient, right? The chest is worth 18, the back is worth 18, each of the legs is worth 18. No, each of the legs is worth 9, I'm sorry. Each of the arms is worth 9. The head's worth 9. Now here they've got it listed weird numbers. This is just the front of the head and the back of the head. The head's worth 9. If they've burned half their head, it's 4.5, okay? Or you can go by the palm method, which is the size of the patient's palm on their hand is equal to 1% of their body area. I always thought it's funny how they give 1% to the genitalia. It's like, well, I mean, come on, give me some credit here. This is different for kids. Remember, kids have bigger heads. Their heads are worth 14, not 9. And infants, it's even bigger. Their heads are worth 18. Where do we take away some of those points? From their limbs. Their legs specifically. All right. Great. So that's how we deal with that. Now, this is the Parkland formula. I don't believe there's a test associated with this. Like I said, though, 4 milliliters times the weight in kilograms times the total body surface area burned over 24 hours, half in the first 8, half over the next 16. lactated ringers preferably to normal saline. We don't even carry lactated ringers here in San. No, that's not true. We do carry lactated ringers. Now I think about it, they're in the fluid bin. We don't use lactated ringers for anything other than burn patients and pregnancy, or childbirth, I should say. Everyone else gets normal saline. Everyone else. Lactated ringers are better. They're not always necessary. All right. Orthopedic trauma. This will be the last thing we'll cover today, and then I'll cut you guys loose little bit after, well, and I'll cut you guys loose real soon, I promise. I just want to cover a few more things on trauma. Most of trauma is fairly simplistic. And by that, I mean it's straightforward, not necessarily simplistic, because the long-term effects of trauma are very complex, right? I just described to you guys burns, how complex that injury really is. As far as our involvement in it, though, fairly straightforward. So the big thing for orthopedic trauma is most of this is going to be fairly minor. All right. With orthopedic trauma, we're primarily focused on the extremities and bones and musculoskeletal injuries. So now we're going to talk about specific things, right? Sprains, strains, and automobiles. Just kidding. All right. We know that the musculoskeletal system provides body framework, protection for internal organs with the rib cage, movement, red and white blood cell formation. Orthopedic injuries can disrupt any of these processes. By the way, real quickly while we're talking about it, here's something I cover in the EMT class that I don't cover in the paramedic class. We're talking about bones. There's some really interesting bones in the sternum, right? There's the manubrium, which is the top part of the sternum. It connects your clavicles to the sternal body. Then there's the main body of the sternum, the thing we're compressing when we're doing CPR. It works great. Finally, there's that little stabby guy hanging off the bottom of our sternal body. Does anybody remember what that thing is called? A little sharp, kind of stabby looking protrusion. It has a weird name and it starts with an X. The xiphoid process is correct. Is that a bone? Anybody know? I mean, that's a bone, right? It's actually, it's cartilage. Xiphoid in Greek means sword-like or spear-like, and it makes sense. Now, when we're babies, that xiphoid is made of very soft cartilage, but it hardens over age. It is not a bone. Remember, your ribs don't connect to your sternum bone to bone. They're connected through cartilage. So when we're doing CPR, those first couple compressions are going to be tough and they're going to be crunchy. Most CPR we do, at least in the EMS side, is on geriatric patients. Younger patients, guys under 30, women under 30, it's not quite as crunchy. There's a little more give to it. But for most people over that age, yeah, the first couple compressions are going to be really crunchy. And then once you break down that cartilage binding, it gets a lot easier. When you've been doing CPR on someone for about 20 minutes on old granny, it feels like you're pressing on a waterbed at the end. So here's one of the last things I want to cover here. Fractures, dislocations, sprains, strains, and compartment syndrome. They're not all treated the same. They're different. Now, most of them are going to be treated the same. Sprains and strains are going to be treated pretty much the same, which is that acronym RICE, R-I-C-E. Well, obviously that's how you spell rice. Rest, ice, compression, elevation. Although the NREMT is getting away from elevation. Now, for you in your home consideration, go ahead and elevate. Fine. No problemo. Ice it, ibuprofen it, rest it, put a compression bandage on it. That should take care of most of these injuries. Now, can anyone tell me what the difference between a sprain and a strain is? I'll give you a hint. That one has to do with ligaments and one has to do with tendons. But while we're on it, what the hell's a ligament and what the hell's a tendon? This is the last thing I want to cover. And then once you guys understand this, I think we'll all have a better handle on trauma. What's a sprain? What's a strain? What's a ligament? What's a tendon? Why does it matter? Or does it matter? So don't worry, I'm going to give you guys a nice way to remember this stuff, but I'll give you guys a second if you guys know one. Bone to bone ligament. That is correct. Would that be called a sprain or a strain if we tear a ligament or damage a ligament? This is where the real tests come in. Strain. Ow, so close. You guys were both so close, but so far. It's a sprain. Here's how you guys can remember this. A strain has the letter T in it. So does the word tendon. Muscles are tender. Tendons connect muscles to bones. Tendons become strained. Now that I've told you guys, hopefully it sticks in your head. It's easy. There's a T in strain, there's a T in tendon. Muscles are tender. Ligaments and bones, not so tender. Now, both are important, ligaments and tendons. But one of them, and by the way, what makes someone more or less athletic and have faster or slower reaction times and be stronger or weaker is almost entirely dependent on how tendons form to bones and how ligaments attach bones in convenient ways. Where your tendons connect to the bone determines the overall length and strength of our muscles. All right. Okay, guys. So, sorry, there's some moms outside with some babies, and they just pulled a bike over. I was just making sure they're okay. Everyone's good. All right. So, strains and sprains affect those ligaments. Or, I'm sorry, sprains affect ligaments, strains affect muscles. So now that we know, should be easy to remember. Which of those is going to take longer to heal? Generally, ligaments take a little longer to heal because muscles have a little better blood flow. Bones have great blood flow, but not always to the ligaments. So those generally might take a little longer to heal. They both can be serious. Some of the placement of ligaments helps us see how much flexibility we'll have in certain joints. For example, there's a bunch of ligaments in the knee, like the ACL, the anterior cruciatus ligament, and the MCL, the medial cruciatus ligament. I think there's even a third one in there. I can't remember its name. You guys are probably familiar when an athlete is really good at sports and then they tear their ACL, they're never going to be quite as quick or have quite the same flexibility in their knee as they did before. However, if they tear one of their other ligaments, like the MCL, sometimes that can actually increase flexibility. We obviously would like to keep all of our ligaments and all of our tendons in place. But if they get damaged, they take longer to heal than muscles do. And unfortunately, there's not that much we can do about it. So that's why the only thing we really have to treat them is RICE: rest, ice, compression, elevation. Then we've also got fractures and dislocations. Now, a dislocation is also known as a luxation. There's another word for it. I think it's the Latin word or the Greek word or something. Now, we also have something called a subluxation, which is when a joint will pop in and out of the socket. Think about in your shoulder if that's ever happened to you. By the way, if you've ever dislocated something, the chance that you'll re-dislocate it is very high. My brother's wife has a younger sister who's dislocated her knee 3 separate times. Once from playing volleyball when she was young, and then twice others just from doing regular things. In fact, that's actually how I met my brother's, at the time it was his girlfriend's younger sister for the first time. I responded to a call. She had gone down and her leg was dislocated and bending the wrong way. And I showed up and I was treating her and she looks at me and she goes, "Hey, are you Eric's brother?" And that's not a question I'm used to being asked in an ambulance. I said, "Yeah, how do you know that?" And she goes, "Oh, he's dating my sister." I was like, "Oh, well, it's nice to meet you." You've dislocated your knees, both knees, or just one knee, Molly? Both. Ay, ay, ay. I'm sorry to hear that. What was the original injury that caused the dislocations? Or was it both at once, or was it one at a time and then the other? What's going on with that, Molly? I would wear leg braces if I were you. Goodness gracious. I'm terrified of dislocating my knees and elbows. Chasing your brother around the house. Oh, Molly, Molly, Molly. How old were you when that happened? You guess like under 10. I hope under 10. You're like, no, I was 37. Oh God. I hope your brother felt bad about that. I mean, I'm sure he didn't feel bad about it for very long. I've got sibling. I have a brother too, so I know how that goes. Yeah, not at all. I was so nervous you'd say that, but hey, that's what happens sometimes, unfortunately. Yeah. The thing that can help is building up the muscles and strengthening your legs, your upper legs and lower legs, strengthening up the muscles around them, working with rehabilitative therapists and occupational therapists and physical therapists, trying to build that up, and using braces. However, I'll say this about braces. Sometimes braces do more harm than good. And here's why. If you rely on a brace, then your muscles will atrophy, okay? If they need to support themselves, including the quick twitch fibers that help you balance side to side, then the brace is going to actually weaken that overall. So use a brace after the injury, but try to work out the muscles around it, and that should prevent it. And then just realizing things that are likely to trigger it. Unfortunately, if it's happened a few times, it's probably going to happen again. But you also, it's happened a few times, so you know how to deal with it and things that can go on. Just look forward to the fact when you get to eventually get a knee replacement surgery when you're like 70. That's you got that to look forward to.